we'll be talking a little bit about some trends in epidemiology, exploring the phenotypes of the various patients with acute and recurrent pericarditis, and then talk about the autoinflammatory pathway. And then finally discuss some emerging therapeutic strategies, especially with immunomodulators, and what does future hold for this very, very old disease, and why are we learning so much about it now? And as Dr. Taylor said, this disease is very, very old. And as was outlined by Dr. Osler in 1909, probably no serious disease is so frequently overlooked by the practitioner. Postmortem experience shows just how often pericarditis is not recognized or goes on to resolution and adhesion without attracting notice. And a lot of it holds true even today. The diagnosis management can be very, very unclear and vague for most even cardiologists. And this is a little bit of the anatomy of the pericardium itself. It's a double-layered sac that we know, which has very intricate attachments to the posterior aspect of the mediastinum, and these are some reflections where it gets attached to the sternum. And finally, it is rich at its base in epicardial fat. And this is a quick video that I put mostly for house staff here to really harness the point that the pericardium itself is a dual layer membrane and has a visceral layer and the parietal lamina and part of the serous pericardium. And then it has a fibrous pericardium which overlays it. And in between here, you have your pericardial fluid. We all have some presence of pericardial fluid here. Typically, when it's less than 50 cc, it shouldn't really cause any trouble or hemodynamic compromise. It's usually when it's getting bigger that it starts to get more noticeable, and we start to think of pathology there. But really, this just shows how the actual pathology, the histopathology of the pericardium is so important, and something that we really rely on our patients who undergo a pericardial window or pericardiectomy, is that you can truly trace back how the disease has really progressed. A normal pericardium, as you can see here, is very rich in mesothelial cells in the epicardium of the visceral layer, as well as the fibrosa of the parietal layer. And a normal pericardium in health should not have a lot of vascularization. So if you're seeing a lot of blood vessels, granulation tissue, and deposition of hemorrhagic substance, those are probably suggestive of more advanced disease. In terms of the clinical syndromes in pericardial disease, there is a list, as you can see here. For the purpose of this talk, we'll mostly be talking about the acute and recurrent pericarditis, and then touch on pericardial effusion, tamponade, and then constrictive physiology. In terms of the epidemiology of acute pericarditis, we don't truly know the actual epidemiological data, and it's been noted to be 3 to 30 cases per 100,000 person years and 5% of ER visits. I tend to think these numbers really do not reflect the burden, and we'll talk a little about how we really, really underdiagnose this problem. And this is a very long list of etiology, and really talking about individually about all of them is beyond the scope of our talk. But the more important ones are the following. Here in the United States or in any developed region of the world, this is most likely an idiopathic cause, something that we associate with a viral etiology. And as you can see, in the more developing regions of the world, it is usually an infectious cause, with tuberculosis being the #1 etiology of pericarditis and recurrent pericarditis and effusion. And then autoimmune disease and malignancy tend to be somewhat equal in terms of their prevalence across both developing and developing regions of the world. And I put SLE and RA here, and just to highlight how these tend to be the more common autoimmune diseases which favor an association with pericarditis, and less so other autoimmune diseases. In terms of etiology and outcomes of pericarditis, I thought this was really interesting. This was published in 2020 based on looking at a cohort of patients based on a pharma registry, where they found roughly about a third of patients in the United States up until 2020, and they looked back about 2 decades, had evidence of post-cardiac injury syndrome. So the reason they had pericarditis was likely an iatrogenic etiology. And really, this is important in an era, especially since we're part of Washington Hospital Center, where we do a ton of these very, very advanced transcatheter procedures and ablations. So it is especially important to recognize that those procedures really carry a risk of post-cardiac injury syndrome as well. And it has really been found acute pericarditis is most likely to affect young men. There have been animal studies showing that testosterone can lead to myocarditis with exogenous increases and can lead to viral replication and inflammation. And perhaps it is less common in women due to slightly protective effect with estrogen, and hence the incidence of pericarditis in women is really highest during the postmenopausal period. And I think it's really important to talk about cancer in the pericardium. There are various reasons why patients who have malignancy can have pericardial disease. This is limited to the disease itself. Primary pericardial tumors tend to be profoundly rare, but malignancy is slightly more common. But it is usually your treatment, the chemotherapy itself, and especially the radiation and dose-related injury to the pericardium, which can increase your risk of constrictive pericarditis. About a decade or two ago, constrictive pericarditis related to radiation carried one of the most adverse prognosis. But as we're learning now, we've made a ton of progress in how we dose these radiations, and hence constrictive pericarditis related to radiation is not as common. And as you can understand here, the mapping, the planning of where you want to focus your radiation to and how much dose you want to give, that is becoming more and more nuanced and individualized. So perhaps in another decade or so, we'll be seeing less and less of radiation-induced constrictive pericarditis compared to what we see today. And as Dr. Taylor said, diagnosis is with regards to care of exam is very, very important, as was recognized by Dr. Osler. Our guideline that we have for pericarditis is this 2015 document from Europe. So we unfortunately don't have any recent American guidelines, although that is really something where all pericardial disease centers across the country are really pushing for our own set of American guidelines that are more recent. And as you can see here, this is more for the house staff and something that's heavily tested in the medicine and the cardiology boards, is how you define pericarditis as atypical pericarditic chest pain, which will be pleuritic and will refer to your shoulder, your trapezius, a pericardial rub, new non-contiguous leads with ST elevations or PR depression, and a new or worsening pericardial effusion. And then you have these additional supportive signs, as is shown here, elevation of markers of inflammation as ESR-CRP, leukocytosis, and then finally evidence of inflammation on CT and MRI. And this is, again, important to note, but every patient should be undergoing at least an echocardiogram, a chest X-ray, and cardiac enzymes to rule out other associated pathologies, or what can really mimic pericarditic pain could actually be true acute coronary syndrome. So it is important to note that we should also be checking troponins on this patient, especially because there could be a myocardial involvement and there can be myocarditis in addition to pericarditis. This is something, takes us back to our med school days, but the PR depression and ST elevation and diffuse leads. However, in practical life, only 40% of these patients truly have a diagnostic EKG. So by the time they get referred to us at our program, they have already normalized their EKG. So absence of these typical EKG findings should not deter you to start thinking about a history of pericarditis. And in how we classify pericarditis, if it's less than 4 to 6 weeks, it's acute. Incessant will be more than that. And recurrence, as Dr. Taylor also shared in his story, is when you have a symptom-free interval of 4 to 6 weeks. And chronic, which is not something we see very often, we tend to see more recurrence than chronicity, is pericarditis lasting for more than 3 months. And it is important to note that if these patients, as I had alluded to earlier, if they have raised cardiac enzymes, we want to think about myocardial involvement. And this will be best diagnosed and stratified, as is shown here with these MRI images, where we're looking for hyperintensive water-based tissue characterization as well as late gadolinium enhancement, which can suggest inflammation. So, and we tend to hear a lot about perimyocarditis and myopericarditis, and anytime I say that, the house staff, they're trying to figure out which is which, and it's really what is your predominant problem. So if you have predominant pericarditis with some myocardial involvement, that's myopericarditis. And if you have predominant myocarditis with pericardial involvement, that's perimyocarditis. So the latter half will show what the predominant problem is there. And really, the outcomes between both are pretty comparable, although myopericarditis tends to have slightly higher recurrence rate. And these are just some patients that you want to consider admitting to the hospital. If they're very febrile, if they have a large effusion, and certainly cardiac tamponade, which is an emergency, which we'll see shortly. And I've also added anticoagulation here because by definition, if patients have a large effusion, they're in anticoagulation, they really need to be watched. The incidence of tamponade is going to be higher. Now, how does the pericardium respond to injury? I've used a lot of words about acute pericarditis and recurrent pericarditis. And really what's happening is that you tend to get a lot of neovascularization. This is a histopathology from a patient with acute fibrinous pericarditis. And as you can see, there's a lot of neovascularization here, deposition of granulation tissue, which was not seen in a normal pericardium. And as this becomes more recurrent, you get more fiber or hemorrhagic exudate. And you get more organization. So if you look at this, this is really a chronic burnt out pericarditis waiting to happen if you do nothing about it. Now, the interesting stuff, how do you image the pericardium? Acutely, as I said, every patient should be undergoing an echocardiogram. Not every patient with their first index episode deserves an MRI, although if it becomes more recurrent, we should be doing some advanced imaging with a cardiac MRI. And if we're thinking of a more constrictive picture based on exam or other findings, those patients are best served with a CT to be assessing for calcification in their pericardium, especially for pre-op planning. And this was very well laid out by the ASC document by Alan Klein in 2013. If you're, when should we do CMR and CT beyond echo? Really, if your echo is inconclusive, if you have other findings which you think are not being answered on the echo, as well as I said earlier, constrictive physiology and associated trauma, those are patients you want to really look at their CT and MR. These are images by our fellow, Dr. Ian Welch. This is his 4 a.m. echo on a patient with an autoimmune disease who actually came in with tamponade despite having really good control of her autoimmune disease. And we'll talk about how, we can delineate autoimmune and autoinflammatory problem. But in brief, as you can see here in this echo, in this peristernal long axis view, that's the left ventricle here, and there's a large effusion. The heart has this swinging motion, and you can see this buckling and compression of the right ventricle. So this patient really was sick, and as I don't know if it's showing up here, but she was pretty tachycardic symptomatic. Tamponade, though, is still a clinical diagnosis, and your ultrasound can be helpful in gauging and understanding what's really going on and the characteristics of the fluid. But let's not forget to still diagnose this with our exam findings. So really, echo has a very important role in infusion, looking for constrictive and LV dysfunction, and it deserves to be noted again that the rate of accumulation is the key here. So the same amount of pericardial volume, if it is accumulating very quickly, will cause very quick elevation of pericardial pressures as opposed to a slow fusion, which will take a little bit longer. And hence patients with end-stage renal disease or any chronic problem will tend to tolerate these effusions for a long time and be completely asymptomatic. And the way we delineate this classification on echo is if it's less than a centimeter, it's small, and more than 2 centimeters considered large effusion. And one quick note is the yield of pericardial fluid is very limited. I get this question all the time, especially from our colleagues in medicine and rheumatology as well, is, did the pericardial fluid help you in any way to arrive at a diagnosis? And yes and no, and perhaps more no than yes. The reason being, the criteria that you use for other fluids, including the fluid from your peritoneum, acidic fluid, ascites, or pleural fluid, tend to be more helpful when you're trying to gauge what the etiology is, be it transudative versus exudative. That doesn't hold true as much as for pericardial fluid. Rare exceptions being in malignancy, where this can be tremendously helpful. And I put this here, this is again very rare, but the boards love to test it, so I put this for our house staff here, is that tuberculosis will have a high adenosine deaminase, which is an enzyme, and rheumatoid arthritis has a low glucose in terms of their assessment. And this is what we're looking for. And I'm very grateful to our colleagues in advanced imaging that I refer a lot of these patients to, but I think cardiac MRI is crucial in diagnosis, prognosis, and really guiding our therapy. And as you can see here in these blood spin images, you're showing some pericardial thickening as is seen by this arrow here. And then as alluded earlier, you look at some water-based tissue mapping, including T2 stir sequence as is seen here, which is suggestive of ongoing pericardial edema. And you match that with late gadolinium enhancement, as is shown in this sequence here, with severe circumferential pericardial enhancement. And anytime you see this, you know this patient is going to be very, very symptomatic. And CT has its role in perhaps pre-surgical planning and when you're concerned about constrictive pericarditis. And normal pericardium will be this thin structure as is shown here with these arrows. But the more chronic and recurrent and remodeled your pericardium becomes, the more calcific it becomes, and then CT then becomes your tool to really understand how to stratify these patients and refer them for surgery. And this will also show up on X-ray. Let's never forget the importance of combining all imaging markers, including this enhancement, this radio-opaque lining here, which is the heart border being completely calcified, and you can see on fluoro image as well. With this patient with constrictive pericarditis. And really, this is beyond the scope of our talk, but in the interest of time, this is really a problem with the association of your intrathoracic and intracardiac pressures, which make for some very, very interesting hemodynamic findings. And with the board favored being simultaneous RV and LV tracing showing this square root sign, and equalization of your diastolic pressures across all chambers. And what we're looking for in echo are really inspiration and any septal changes with inspiration and expiration, which can be seen on cardiac MRI as well at rest or perhaps with some breathing sequences. So really, in summary, the strengths of cardiac MRI, well, it really is important for all spectrum of inflammation for pericarditis. It's really for calcific burned out disease, as well as for surgical planning and trauma, that CT has an important role. So now about some anti-inflammatory therapy. We're all aware of, acute and recurrent pericarditis. These patients need a cocktail of aspirin or ibuprofen. So really an NSAID with colchicine. Colchicine for 3 months and your NSAIDs for a few weeks. And if patients have had recurrence, you extend the same regimen. At least that what was being done conventionally and traditionally is you extend that to 3 to 6 months for colchicine, and you extend your NSAID therapy as well, and you do a much slower wean. And really the data for colchicine comes from the COPE trial and the ICAP trial, which showed in COPE trial, you saw that there was really a lower rate of recurrence, and then ICAP was bigger with 240 patients, and they looked at the European dose of 0.5, and up until recently, we had a 0.6 milligrams, but after Ledoco, we have, which I'll talk about shortly, we have 0.5 milligrams available as well. But really, that's where the data for colchicine comes from. However, NSAIDs actually don't have any robust randomized controlled trial to show its effect. The benefit of NSAIDs and its role is based purely on clinical experience. So while colchicine has robust randomized trials and more meta-analyses, which are coming out every month to show how beneficial it is, that does not hold true for NSAIDs. And we really should be counseling our patients about GI intolerance and other side effects with it as well. And steroids, as much as our boards like for us to think, or the rather obsolete recommendation, which had been to consider steroids in these population, we're learning more and more that we want to avoid it in the acute and recurrent pericarditis population. And this was also seen in the COPE trial as well by Dr. Mazio, that steroid use independently increased the risk factor for recurrence by more than 4 times. So we want to be very, very careful. And while ESC wants us to think of steroids as a second or third line, I try to reserve this in situations where we have no choice. In certain autoimmune diseases, immune checkpoint inhibitor-induced pericarditis, and it can really be associated with prolonged risk and increase your recurrence. And I just thought this was interesting to note that up until recently, we had no data to guide us for perimyocarditis. If patients have myocardial involvement with pericarditis, do we give them NSAIDs? A smaller study in animals showed possible harm. But this study by Dr. Mazid was a retrospective observational study that showed there was actually improved disease-free survival for these patients who received colchicine for the same amount that you would do for an acute episode of pericarditis. So colchicine is still very, very reasonable in perimyocarditis as well. And pericarditis and systemic disease, this is extremely high yield to recognize that there are going to be some autoimmune diseases which will also be associated with pericarditis, the big ones being lupus and rheumatoid arthritis. And then there are these autoinflammatory diseases with the prototypes, being your TRAPS and familial Mediterranean fever syndromes, which start early in childhood. And these autoinflammatory syndrome really is an aberrancy in your innate immune system. And you tend to not have a lot of antibodies and has more monogenic genetic predisposition, whereas systemic disease tends to have more of your humoral antibodies. And as I said earlier, lupus and rheumatoid arthritis are your big ones. And lupus tends to be especially important. Up to a quarter of patients with lupus can have associated pericarditis. However, it will only be associated with labs that truly show a lupus flare if you are invoking a lupus-related pericarditis. Their labs should show positive ANA, dsDNA, and low complements and cytopenias, as is true for rheumatoid arthritis as well. This is not as common as lupus, but certainly something to think about. And with better therapies with rheumatoid arthritis, it's becoming less and less common, which has been attributed to better disease control. And now we get this question all the time. Do we refer every patient with pericarditis to our rheumatology colleagues? Perhaps no. You really think of systemic disease or autoimmune disease if there has been recurrence, or if their phenotype is very inflamed, if they're coming in with really truly high fevers, documentation of CRPs, which are very elevated, a lot of leukocytosis. Pleural effusion and multisystem involvement in female, I think these are derived more from the lupus population. So really, every patient does not need a referral to our colleagues in rheumatology, but certainly we want to start thinking about it. But this really hedges on a good history-taking skill. And our house staff who are really at the forefront of this, and what I always say is, patient will not volunteer a history of inflammatory arthropathy or lupus, or I took, or a family history of autoimmune disease. We have to ask them in various different ways. So recurrent pericarditis, now the fun stuff, is seen in up to between 15 to 30% of patients. And the more recurrences you have, the more prevalence of that recurrence is going to go up. Tamponade and constrictive pericarditis is rare, but it's important to note that if you're having an idiopathic or a viral-related pericarditis, the prognosis is going to be better compared to patients who have a specific etiology, let's say an autoimmune cause, malignancy, or constrictive pericarditis related to radiation. So idiopathic viral pericarditis still holds a relatively better prognosis. And this is from Ellen Klein's database that was published in 2020, where looking at over 7,000 patients across the US based on data from a pharma, where up to a quarter had at least one recurrence. And there is substantial morbidity associated with recurrent pericarditis. We tend to hear that these patients typically will have a low mortality, which is true. But I had a patient tell me, "Doc, I wish it was truly a heart attack because you all would have stented me and I would have felt better by now. This seems such a chronic, incessant, resistant problem that I don't know what to do about when each time you tell us about this data of mortality." So there's an ability to perform daily activities of living, and patients have to change their jobs. Also, it is important to know there's a lot of ED visits. And anytime I acquire these patients from the community with acute or recurrent pericarditis, I'll see a ton of ED visits if they're within the MMG system, all with chest pain, and their troponins will be checked, EKG will be unremarkable, and they'll be sent with some element of a follow-up. So there's true healthcare costs associated with underdiagnosing this problem. And who are those patients who are going to recur? If you treat them inadequately, incomplete response, or as I said, a very inflamed phenotype, are some predictors of recurrence. So really, patients who've had significant moderate to severe delayed enhancement, or they're on their CMR, and baseline patterns such as chest pain and CRP, but delayed enhancement across the spectrum of disease is really going to be a true predictor of recurrence in this population. This is from Jack in 2017, where they looked at 159 patients, and those with moderate to severe delayed enhancement had the shortest time to recurrence and the highest rates of recurrence. as is the level of your CRP. So anytime I require this patient, the first lab I look at was their index episode and what happened then. Was their CRP off the chart in the 100s, 150s or above? Those are patients who have really declared a very inflamed phenotype and have declared that these are patients who will likely not respond to the traditional, rather obsolete cocktail of aspirin and NSAIDs. And challenges with diagnosing recurring pericarditis are very important. This is a study also from Open Heart in 2018, where they found that patients, if we look at these 4 criteria, so firstly, these were 200 patients, and they all underwent CMR and inflammatory markers. Only 45% had only 1 or no signs of recurrence according to this definition that we have by ESC. So if you're only going by this criteria, which we can all recognize as very, very important and has a very good positive predictive value. But recurrences can be fairly atypical and can really, really fool you. So we really want to be thinking about some advanced imaging with cardiac MRI for these patients because we'll be missing them. So what is this new paradigm of recurrent pericarditis that I was alluding to in the beginning of my talk, and how is that different, and where are we with that disease? So for this new paradigm of recurrent pericarditis, well, the older hypothesis was that recurrent pericarditis is an idiopathic problem, is a viral problem, and we don't know what the virus was. The patient has already cleared it, and the patient will not give you a good history. But we're learning this is an autoinflammatory disease now, and this is what the changing paradigm in our management is. And the wheels of these thoughts were already being laid back in 2018, even before the publication of our landmark trials with new immunomodulators, where they recognize that idiopathic, this very term, it elicits a sense of complacency. Anytime we use these patients amongst each other, with clinicians or with patients, patients tend to think, oh, it's so you guys can't figure out what I have. You don't know what caused it in the first place. And a lot of times I've had some patients in the community also use the word, well, they thought it was an idiot. They thought it was an idiopathic problem, so nobody can figure out what that meant. And so we really want to understand what is this autoinflammatory problem. And there has really been an explosion of publication with these biologics. So how do we tie the two together? It's really understanding the spectrum of autoimmune and autoinflammatory problems. As I alluded to earlier, if you've had problems with your innate endogenous danger signals, with interleukin-1 and interleukin-18 production aberrancy, you tend to have more autoinflammatory diseases, and your autoimmune is basically an aberrant activation or self-activation, which is very persistent related to T cells and B cells. Acute recurrent pericarditis probably lies somewhere here. It is an organ-specific autoinflammatory disease, and I'll tell you why. We have derived this hypothesis based on similarities to other inherited disorders, which entail a similar pathway from the enemy of every autoinflammatory pathway, which is the inflammasome, and the response to treatments that target that inflammasome. And this has been studied very, very, very in older trials as well with colchicine, interestingly, an ancient drug which has known to have potent anti-inflammatory properties. We had seen the effects with pericarditis. We talked about the COPE trial and the ICAP trial, but really there are more trials and more studies coming for other spectrum of clinical disorders, including a recent study in New England Journal where they found colchicine has its role. This is a Lodoca trial in patients with obstructive coronary disease for secondary prevention. And in this study where they found it also has a benefit as an anti-inflammatory therapy in patients with malignant pericardial effusion. So, and how do we look at the mode of action of colchicine? It really boils down to it being concentrated preferentially in the white blood cells. And if there's one thing you should take away from one of this talk is the role of the NLRP3 inflammasome, which is something that we all rely on to really generate an autoinflammatory, response to a trigger. However, if there is an aberrancy, if there's a dysregulation of this NLRP3 inflammasome, be it from an inherited monogenic disorder such as FMF or recurrent pericarditis, that is when you need further advanced therapies. And as you can see here, colchicine can really attenuate this response at the NLRP3 inflammasome and will also inhibit your tubulin polymerization. And the data with regards to colchicine and recurrent pericarditis, the wheels were starting to spin in 1980s when they saw patients who were steroid dependent. And the authors put in their description, the reason they chose colchicine for this endeavor was on the basis of colchicine its benefit in recurrent polycerositis in the FMF population, another ancient disease. And this is just a quick slide showing how anakinra was later found, and this was from 2009, from data showing 3 patients who had this interesting ebb and flow in their C-reactive protein anytime they received anakinra, which is a subcutaneous daily dosing, and they had this fall in CRP, which became very, very predictable and really led to anakinra being more used in the recurrent pericarditis. I will not talk a lot about this. This is basically a very advanced slide, but I do want to talk about 2 things here. One is that the inflammasome gets triggered by either pathogen-associated or damage-associated molecular pattern, and downstream it leads to activation of interleukin-1 beta. And this really forms the basis of your immune modulators, and this is why these immune modulators work so well, especially using recurrent pericarditis as a pertinent example, where previously we'd use immunoglobulins and colchicine and steroids. Now we're using these newer biologics, and anakinra being one of them, which is not as new, but certainly newer in the recurrent pericarditis population. But one important thing to note here is that your steroids and your NSAIDs are really acting at very distal pathways. So your steroids and your NSAIDs are not really disease modifying. So if you were to do due diligence for your patients with a recurrent pericarditis, be really absolutely certain that they are on colchicine. And if they're not responding to colchicine, those are patients who can be referred to us, but can certainly be considered for immune modulators, because these steroids and NSAIDs are probably just attenuating their symptoms and inflammatory markers, but not altering the course of their disease. And finally, there are some trials that have been really, really important in our population that deserve attention. AirTrip trial being one of them, which basically looked at a smaller cohort of 21 patients who had increased flare-free survival and days free of recurrences with anakinra, an interleukin-1 receptor antibody that we had blocker that we had just seen. And this is from the IRAP registry, which basically widened more data in this population and found continued benefit. But the most important landmark publication that has come out in the few years has really been the Rhapsody trial by Alan Klein, who was a primary investigator up at Cleveland, amongst other authors here, which really showed a astronomical improvement in patients' recurrence. And again, these patients had about 30 patients, so not a very large study, 30 patients in each arm, where they found the median time to pericarditis and recurrence was significantly reduced in patients who were treated with 12 weeks of rilonacept. And this is from AHA that came out, and this was presented at 2022, where they found continued rilonacept beyond 18 months. It resulted in continued treatment response. So one question that I receive from patients and other clinicians all the time is, how long do you want these patients to be on rilonacept? We'd previously vaguely thought maybe 1 year would be sufficient, but prolonging their treatment to 18 months and beyond really reduces your freedom from pericarditis recurrence. So this is highly important to recognize. And FDA has approved Pericardial. This came out in 2021 after the Rhapsody trial. So at this time, rilonacept is currently the only FDA-approved immune modulator in our armamentarium. Certainly, we do use anakinra in select population and other immune modulators, but where FDA is concerned and insurances are concerned, rilonacept is the only biologic that we have. And this is just a quick slide which beautifully shows how these immune modulators are interacting with the interleukin-1 receptor. With anakinra being a true interleukin-1 receptor antagonist here, and this is your receptor here in this cartoon. And rilonacept is a trap decoy analog of the interleukin-1 alpha, interleukin-1 beta, as well as the interleukin-1 receptor. So rilonacept does not really interact with the receptor, but it's interacting with the interleukins as well as the receptor here more proximally. And canakinumab, which we do not use much in the acute pericarditis or recurrent pericarditis population, we don't have much data for it yet. This is a human monoclonal antibody for isolated interleukin-1 beta, and it does not have much to do with the alpha or the receptor. And these biologics are fairly well tolerated. Another question with regards to safety and their half-life. So anakinra tends to have the lowest half-life, and this has to be taken. Firstly, all three are subcutaneous injections, but anakinra has to be given daily. Rilonacept has to be given weekly, whereas canakinumab has the longest half-life. Not yet studied much for the recurrent pericarditis population, but can be given about 1 to 2 months. And this came out before the FDA had approved it, so it does not recognize the indication, but now RP is also a FDA-approved indication for it. And in terms of adverse events, really it's the injection sites which tends to be the most common adverse events for these patients. And these tend to be very, very self-limited and can really respond well to just topical a steroid or topical Benadryl can also work for these patients, but the vast majority will resolve on their own. In terms of the spectrum of pericarditis, this is probably the we're nearing the end of our talk, but the spectrum of pericarditis is really, really understanding and locating these patients within the spectrum of pericardial disease. And I'm finding more and more that no two patients with recurrent pericarditis are ever the same. And the way we delineate where they are in the spectrum is really with advanced imaging, including cardiac, which is actually cardiac MRI. And acute pericarditis can tend to lead to recurrence, chronicity, and if left untreated with more recurrences, it can become burnt out. But recurrent pericarditis can lead to a subacute effusive constrictive physiology. So I had shown you some slides earlier about constrictive physiology where you're seeing some dissociation in intrathoracic and intracardiac pressures. The older paradigm used to be that these patients need to be considered for surgery, and this is a permanent problem, but it is likely not. And we're finding that there is a real role of treating them, intensifying their therapy with interleukin-1 blockers, treating them for 3 to 6 months, and as they do as Alan Klein does at Cleveland and as they do at Mayo, we want to get some functional pre and post testing for these patients to stratify their symptoms. And we want to avoid surgery for these patients at all costs. So treating ongoing inflammation is really imperative here, and we want to avoid early surgery. Once they have become burnt out, and as you can see here with MRI findings showing no delayed enhancement, no evidence of hyperintense T2 water-based characterization that would tell you about ongoing edema, these patients are best served with surgery. And at this point, the role of interleukin-1 blockade is probably not there. And this is just a spectrum of what I had talked about as these patients would come on to present to us on echo. You'll be seeing an effusion, and you'll be seeing persistent T2 water-based abnormality and delayed enhancement. But as these patients get more remodeled with healing, you tend to see more thickening. But all the hyperintense T2 signals and delayed enhancement are probably not seen when they are burnt out. And lastly, surgical treatment for pericarditis. This is beyond the scope of our talk, but since we have a very robust team of cardiac surgeons, and I've referred patients to them, and one story that I'll share shortly was previously really reserved for calcific burnt out pericarditis, but now there is an emerging role for pericardiectomy for the recurrent pericarditis patients as well. So think those patients who've had significant recurrences in their pericardial disease and are no longer able to tolerate therapy, and really patients who are it also has to be a patient-centric choice. Those patients can be considered for surgery, pericardiectomy as well. And the bigger question is, are you offering them radical and or a partial pericardiectomy? And they're finding at Mayo that they had really good results with more radical than partial pericardiectomy. And this was basically a small cohort of about 200 patients that they looked at, and they found that the best results with pericardiectomy was interestingly in the idiopathic population, with radiation being the worst. However, as I alluded earlier, we're seeing less and less of radiation-induced constrictive pericarditis And this is a patient who was referred to me by one of our colleagues, Dr. Galino, and cardiology associates, with the hopes that she would be offered immune modulators. But what she really has, as you can see here in the CT, is very, very significant calcification of her pericardium. And even before you look at MRI and you review all the other data, you already suspect that this is someone who will likely not be amenable to any inflammatory therapy. This has really been a result of significant recurrences. But we did send her for pericardiectomy, radical pericardiectomy, to her colleague, Dr. McIvery, and cardiac surgery. And this is what she sent me later. This is basically a week after she had divided all her jewelry and all her property amongst her kids, and she thought she was dying. And then she sent this to me after she's actually now doing extremely well. And it's wonderful to breathe and walk again. Thank you for referring them to me. I must say, I owe you my life. I can't remember the last time I felt this great. So surgery, when these referrals are made the right way and for the right patient, and you're really individualizing care, these patients can really, you can change their lives. And we have to shy away from thinking that this is too high risk, that this is too prohibitive. And just a few couple minutes talking about what does the future hold for pericardial disease. We had talked a lot about, we took a trip from the ancient Colchicine times to various pathways. So what does the future hold? It's really the intersection, this interplay between underlying genetic predisposition as well as what really persists or what really triggers their autoinflammatory pathways. So this was a meta-analysis amongst this is looking at 5 different countries where they really looked at the association between pericarditis-related variants and various subtypes, and they found that there were at least 2 independent sequences at the interleukin-1 gene locus. So I am getting some referrals from patients who have a pretty dense history of pericarditis in their family, and I am referring them to genetic testing as well. And as I was telling Dr. Welton, I may have caused a backlog with their geneticist with referrals to genetic testing, but really that is probably going to be the future to really stratify what the underlying predisposition is. And this is newer data from last year looking at another interleukin-1 blocker called goflicicep. And this will really, this was just a phase 2 and 3 early data, very similar to what we saw with the rilonacept population with regards to decreased recurrences and improved survival from recurrences. But again, there will be a lot of many years before we will see this approved by the FDA. And I'm happy to share what we're doing, all the work that we're doing at MedStar Washington Hospital Center. We finished enrolling our last patient for the Maverick trial. This was a open-label pilot study looking at an oral treatment for recurrent pericarditis referred to as Cardiol RX, a cannabidiol oral solution, which also inhibits your inflammasome pathway similar to colchicine, and it inhibits your interleukin-1 beta, interleukin 6 secretion. So I'm excited and very, very looking forward to really the results of what we have done for these 25 patients, of which 2 were enrolled at Washington Hospital Center and the remaining were at Mayo Cleveland and other sites. And I just got an email from yesterday that we got approved. Washington Hospital Center is now approved as one of the sites for the Resonance registry. This is going to be the largest registry of recurrent pericarditis patients in the world, really. So they have actively been enrolling patients amongst other pericardial disease centers across the country, including Cleveland, MGH and other centers, and then we just got approved. So very, very excited about that.